This conference will now be recorded.
That's just awesome.
You like awesome.
They do that.
Oh, it is recording. Okay. Okay, cool.
Never mind. All of my names are on. Beautiful, beautiful. Drug cards, if you hadn't already, get them together and we're gonna collect them so you can get a grade. We're gonna let Hannah start real quick though.
Okay, is everybody good? Ready to start? Yeah? Okay, cool. So we're going to start with chapter 13 today. That's vital signs and monitoring devices. So vital signs are the outward signs that may indicate what's going on inside the body. What are some of our vital signs? Blood pressure, pulse, respirations, skin color. Okay, gotcha. Cool. So yeah, pulse, respiration, skin color, skin temperature and condition. Pupils are another one that are often overlooked. Blood pressure, and then O2 saturation. I think in your book it actually says that your oxygen sats are actually not a vital sign, but it is something that we typically take pretty much on every patient, right? So baseline versus repeat vital signs. So what are our baseline vital signs? What does that mean? The first set that we get, right? That kind of gives us, like it says, a baseline of where our patient's sitting. And from there, our repeat vital signs are going to show us trends. What is a trend? What does that mean? What's happening over time with our patient, right? Whether they're getting better, whether they're getting worse, or staying about the same as when we took that first baseline set. So first, we're going to talk about our pulse. So the pulse is the palpable pressure of the heart beating. So where are some areas on the body that we can feel a pulse? Radial, carotid, femoral. What about pedal? Pedal pulses, popliteal. I think that's on the back of your knee. So two factors to consider when we're talking about pulse. We want to look at our rate and we want to think about the quality of our pulse. So these are just some of the areas that we just talked about. Yeah, so popliteal right on the back of your knee. I think we mentioned all those other ones, so did good there. Cool. So the rate is the number of beats per minute. How can we determine what our pulse rate is? Count it, yeah, perfect, yeah. So I typically will count for 15 seconds and then multiply that by 4 to get how many beats per minute, right? So normal adult values, any values that I show you are typically going to be adult values. I don't have ped values memorized in my head, so that'll be something you'll have to kind of look for in your book and memorize on your own. But normal adult values, 60 to 100 beats per minute is a normal heart rate for an adult. Tachycardic is going to be above 100 beats per minute. Bradycardic is going to be below 100, or I'm supposed to say 60 beats per minute here. Sorry, typo, my bad. So what might cause tachycardia in a patient? Drugs, that's a good one. Caffeine, cool. What about exercise, anxiety, things like that, right? What about bradycardia? Drugs, yeah. Perfect. Yeah. Shock, that's perfect, yeah. Okay, so we just talked about the rate, our pulse rate, and now we need to consider the quality of our pulse. So the quality means the rhythm and force of the pulse. So rhythm, it can either be regular or irregular. A regular pulse is going to have a regular, even beat to it, right? Irregular is going to be more sporadic, not that regular, normal beat, right? And then we look at the force. So is it strong or is it thready and weak, right? So when you feel your pulse typically on yourself, it should feel like a strong, nice, very palpable beat. You should be able to feel it nice and strong, right? Sometimes though, when you're feeling on a patient, that's maybe bradycardic or whatever. They might have a thready pulse. So thready means when the pulse feels weak and thin. So it's not that nice, strong pulse that we typically feel. Okay. So next is going to be respiration. So when we're talking about vital signs, respiration refers to the act of breathing in and out. So typically we would say ventilation, breathing in and out, right? But respiration, as when it comes to vital signs, means breathing in and out. So when we think about respirations, we want to look at the rate, the quality, and the rhythm. So again, the rate is just like our pulse rate. It's the number of breaths per minute. And again, I typically will count for 15 seconds and then multiply that by 4 to get my minute rate. Something about counting respirations is if you tell a patient that you're going to count their respirations, they'll start breathing weird, right? Like when you think about breathing, it's hard to breathe normally, okay? So usually what we'll do is we'll take a pulse rate, and after we've gotten our pulse rate, we'll kind of look at their chest and observe their respiration rate without telling them, right? So they think we're still taking a pulse, but we're actually watching their respiration rate. So that doesn't change how they're breathing. It's just a good little trick. So normal adult values, normal for an adult is going to be from 12 to 20 breaths per minute. Tachypnea is basically kind of like tachycardia, fast breathing, right? A greater than 20 breaths a minute. And then we have bradypnea, which is less than 12 breaths per minute. So what might cause tachypnea? Asthma attack, exercise, anxiety. Anxiety is a big one in both of these things. A lot of our patients are going to be anxious. They're going to be scared. You know, we're pulling up to one of the worst moments of their life, right? I mean, typically if you call 911, it's pretty big. So they're going to have that anxiety, which can alter some of these things. And then what might cause bradypnea? Lowered respirations. Drugs, cardiac arrest. Yeah. Cool. Then we want to look at the respiration quality. So this is the quality of the patient's breathing. It may fall into 4 different categories. Does anybody know those off the top of their head? No? Okay, that's all right. So the first one is normal. The chest or abdomen move at an average depth. No accessory muscle use. The second, they could be breathing shallow. They could have shallow respirations, only slight movement of the chest or abdomen. It could be labored breathing. That's an increase in the work of breathing. Use of accessory muscles, nasal flaring, and retractions are sometimes noted there. Or it could be noisy breathing. Typically, noisy breathing is some sort of an obstruction there. So you might hear snoring, wheezing, gurgling, or crowing. So this is just a quick little video of what accessory muscle use can look like. Let me see if I can. So this is in his neck, but you can also see it in those intercostals on your side. But there's a lot of work of breathing there. And so this is going to definitely indicate that there's some sort of issue going on. This is labored breathing. Okay. And then this is just a really quick video about lung sounds. It's going to kind of demonstrate what some of those might sound like, because I feel like it's hard to get an idea until you actually hear it, you know? So this is a wheeze. Hear that there at the end, that. Another type of wheeze. So this, what is stridor caused by? Upper airway, right? So sometimes these are also called wet lung sounds. It just sounds really wet and like fluidy in there, right? And the low pitched is coarse crackles. The next one, this is fine crackles. Kind of sounds like Rice Krispies. Yeah. Okay. So we've looked at the rate and the quality of our respiration. So now we want to look at our rhythm. If you observe an irregular respiratory rhythm in an unconscious patient, you should just report and document it. Respiratory rhythm in conscious patients might vary due to speaking, mood, or activity. So, you know, you can kind of just look at a patient and see if their chest is rising and falling at kind of an equal rhythm. But again, in all of us, it kind of just varies, right? Like if we're conscious and alert and talking, rhythm can vary. But there are different rhythms that you could observe. And if you choose to go on to your AEMT class, I think we'll talk about it more there. But for now, if you notice something irregular, just kind of note it down, or report to your medic and let them know. Okay, next, skin. So does anybody know what skin turgor is? What? Yeah, yep, the recoil of the skin. So on a hydrated, balanced person, if you pinch the back of their hand and let it go, it's going to recoil really quickly, right? But sometimes you'll do that and it'll kind of stay tinted up like that. So that can be a sign of dehydration or electrolyte disbalances, things like that. So not something that you need to know, just kind of interesting. So with skin, we're going to look for color, temperature, and condition. So the color. So the best locations to assess skin color in adults are their nail beds, inside the cheek, and inside the lower eyelids. In children, it's the palms of the hands and the soles of the feet. I think somebody asked about the eyelids on Tuesday, and this is what that kind of looks like. That one on the right there, that nice pink color is a normal skin condition. The one on the left, you can tell it's really pale. So there's probably something going on there. So again, normal coloring should be pink. Abnormal coloring includes pale, cyanotic. What is cyanotic? Blue. It could be flushed, jaundiced, or mottled. And then another note is we can check capillary refill on children. How quickly should your okay, what is the time for your capillary refill? Less than 2 seconds, right? You can check that on adults too, but just on children is more beneficial usually. So this is that cyanosis. The fingertips are really blue and purple looking there. This would be flushing, the red cheeks, probably feverish. Here's our jaundice on the right side. That's normal. On the left, it's pretty pronounced usually when you see someone with jaundice. So, and then there on the right, that would be mottled skin. Okay. So we don't want to only look at color. We also want to think about temperature and condition. So the temperature, it could be hot, warm, cool, or cold, depending on the environment they're in, if they have fever, things like that, right? And then the condition of the skin. It could be dry, moist, or diaphoretic, or clammy, which is cold and moist. Okay. Next is pupils. So the reactivity, size, and equality can clue you into different conditions. So reactivity is, do the pupils respond to light or lack of light? So when we're in a bright environment, what do our pupils do? Constrict, right? Yeah. And when we're in dark, what should they do? Dilate, right? So when we check pupils, we want to make sure that their pupils are doing those things, dilating and constricting appropriately in response to light or lack thereof. If they're non-reactive, there's probably some sort of an issue going on there. What can pinpoint pupils tell you? Do we know? Trauma, could be trauma. Narcotics, yeah. So again, we want to look for size and equality as well. So abnormally dilated, constricted, which would be pinpoint, really, really small, really constricted, tiny, tiny pupils, or unequal pupils can also point to certain conditions. So pinpoint pupils can indicate opioid overdose, and unequal pupils can indicate head injury. So that's kind of what those look like. This is around a normal size pupil. There's dilated, unequal, and constricted. That would be pretty close to pinpoint right there. So this is a really good little mnemonic to think about when you're looking at pupils. I don't know if your book mentioned it or not, but PERL, P-E-R-R-L. So pupils equal, round, and reactive to light. And that's what we're kind of looking for when we're assessing those pupils. So PERL. Okay, next, blood pressure. So what is the blood pressure? Yeah, it's right there. Force of blood against the walls of the blood vessels. That's perfect. So what is the systolic number telling us? Yep, perfect. And then your diastolic is that lower number, and that's telling you the pressure that's remaining in the arteries when the left ventricle is at rest. So systolic, contracted, diastolic is that relaxation phase. Blood pressure, so normal for an adult, 120 systolic, 80 diastolic, so 120 over 80. Anything less than 90 systolic is considered serious. So if you observe that on scene, definitely take note of that, let your medic know. So blood pressure is measured with that word and a stethoscope. I don't know how many of y'all have tried to say that word, but I put a video in to show you how to say the word because
Sphygmomanometer. Sphygmomanometer.
Sphygmomanometer.
Say blood
You can also just say blood pressure cuff. I love that. Okay. Sphygmomanometer. Okay, perfect. So we can take a blood pressure 3 different ways: by auscultation, by palpation, and then with a blood pressure monitor. So the first way we're going to discuss is by auscultation, which I think you guys were just doing in there. So step number 1, we're going to position the cuff on the patient's arm. Okay. Typically, there's a line on that cuff that'll show you where to line it up with the brachial artery. Then number 2, we want to palpate that brachial artery, see if we can find it. Number 3, put the stethoscope over that brachial artery. 4, inflate the cuff. Listen for the pulse sound to disappear. And then once you hear your pulse disappear, you want to inflate 30 millimeters of mercury higher. Then we're going to slowly release that air. Note when you hear the pulse sounds again, and that's your systolic number. We're going to continue to deflate. When the sound disappears completely or muffles, we want to note that number too, because that's our diastolic number. Were there any questions on that? Was everybody able to do that well over there? Yeah? Ish? Need a little practice? It's okay. All right, and then blood pressure by palpation. So we're going to position the cuff, find our radial pulse. So when we're auscultating, we want to find the brachial, because that's where we're going to put our stethoscope, right? But when we're finding a blood pressure by palpation, we want to find the radial pulse instead. We're going to inflate the cuff. I usually go to around 180 millimeters of mercury. That's just what I do. But so we're going to slowly deflate that cuff and note the number when the radial pulse returns, and that's your systolic. You don't get a diastolic number when you do by palpation. So are there any questions on that? No? Okay. And then obviously you can use your monitor to obtain a blood pressure as well. So I think it talks about that in your book, but cuff on, push the button, it reads the blood pressure, right? Pretty self-explanatory, I hope. Okay, so next is oxygen saturation, also known as SpO2. The ratio, so your pulse oximeter tells you the ratio of the amount of oxygen that's present in the blood to the amount that could be carried, expressed as a percentage. So what are some things that might give us a false SpO2 reading? Nail polish, cold fingers, carbon monoxide, that's a big one, yeah. Cool. So interpreting SpO2 readings, normal, It's 100 to 96%. So when I went through school, it was 94%. But just learn this. Mild hypoxia, 95 down to 91%. Moderate hypoxia, 90 to 86%. And then severe hypoxia would be anything 85% or less. So what's the difference between hypoxia and hypoxemia? You can read it. I mean, it's there. That's, use your resources, right? So hypoxia is low oxygen in the tissues. And then hypoxemia is low oxygen in the blood. So emia is that that ending there that refers to blood. So that's like anemia or hypovolemia. SpO2 tells you about hypoxia levels. So to know if your patient is hypoxemic, you would have to do a blood gas, and we can't do that in the field clearly. But okay, next, blood glucose. So a normal blood glucose level is between 70 to 100 milligrams per deciliter. Low BGL is less than 70, and they would be hypoglycemic in that case. And a high BGL is greater than 100, and they would be hyperglycemic. So using a blood glucose monitor, somebody just tell me how we would do it without looking at the board. Go ahead.
Pump the finger, take the tab, sure it's in the machine, angle the machine, blood on the little strip, and let it go down.
Cool. So yeah, prepare the. Yep, perfect. So we're going to prepare the glucometer, test strip and lancet, cleanse the finger with an alcohol prep pad, perform the finger stick, apply blood to the test strip, analyze the reading. Pretty self-explanatory, I feel there too, right? And then capnography. So capnography measures the amount of carbon dioxide during expiration. So that's your end tidal carbon dioxide reading, EtCO2. So the normal range for your end tidal CO2 is between 35 and 45 millimeters of mercury. So your capnography reading indicates how well tissues are using oxygen and performing other physiological functions. Any questions on any of that? I think most of it should be a review. So, okay. Can they? No. I think that's more of an advanced thing, but it's just good to know about. Yeah. Go ahead. I mean, you don't want to push super hard because you'll occlude that artery, right? And then you won't feel anything, but just a, decently firm pressure. If it's too light, you can't feel it. If it's too hard, you can't feel it. Just somewhere right in the middle, right? So if you're palpating a patient's chest when they complain of chest pain, I mean, you want to do it not like super, super hard, right? But also hard enough that if there is pain, they can say, oh yeah, right there, that's where it hurts when you're pressing, right? So go ahead.
So the glucose, so it said about over 100. Like an average is like 170.
Yeah. So
I mean, it's not even in the bad portion.
Yeah. And so that's kind of the thing. Like there are some things and ranges that you'll see in your book that don't always correlate to real life, right? Like, so it's important to know these ranges for your testing purposes. But as you get out in the field and kind of do this for a little while, you'll come to see like, oh, that's not exactly like the book said, right? So. Yeah, exactly. And then, like with heart rate as well, like if someone's really active, their heart rate tends to sit lower just naturally. And so that's not necessarily concerning for them. But for someone like me that is not very active, a 40 heart rate would be concerning. So it's just all patient dependent. It's really a lot of things in EMS are kind of variable. So any other questions on that? No? All good? Okay, cool. Give me like 5 minutes to get the next one set up and we'll go from there, okay? Only 5. That's all I need. Any questions in Austin?
Yeah. I'm curious about where. Mine hasn't changed that much. What? Almost. Yeah. 88. There was some in there, I was like, yeah, it's like that head collision one. Yeah, obviously. I got that. Yeah. Hey, what date did you pick? Days off? Yeah. Obviously not next day. Already gonna be rushing. The whole reason was what's your shit is yeah, the 23rd and 23rd. Well, we're on. I had to do one of those. Are you gonna take PTO? You're gonna take PTO? I'll load it if you want. Really? If you don't have a choice, what are they gonna do? If I knew that, I would have done all the work days. I'm sure they're probably like, they want to see what you track it Big priority where to go. Oh, they're early there. You're out there. He's like, oh, he's
Okay, I think we're all back. Is everybody ready? Y'all ready back there? You're good. Okay. So next up is chapter 14. Everybody good? Ready for this? Okay, cool. So chapter 14 is principles of assessment. My slides are not as pretty as they usually are, so I'm really sorry for that. They're kind of bland, but I know, right? I feel the same way. So principles of assessment. So what you determine during your history taking can help guide your further assessments. So, once we go through the primary assessment, we want to get some background and history on what's going on with our patient today and what their past medical history is like as well. So that, because that can sometimes play into their current chief complaint. So patient history, let's see. So there's two different components to your patient history. What are they? Okay. So history of your present illness and past medical history, correct? Yes. So history of present illness is what is happening today, the present illness. When did this start? All those good things. And then past medical history is, do you have any other medical conditions? What's been going on, before today? Yep. We're going to get into that in just a sec. So your history is obtained by talking to the patient or their family or bystanders that are available. And then again, like we talked about in our scene size up, observations at the scene can also clue you into your patient's history as well. So any medications they have laying around, if you see an oxygen regulator or a nasal cannula in their home, that might give us some clues as to what's going on. So we want to try to develop a rapport with the patient. What does that mean? Yeah, we want to get them to trust us. So they'll tell us, what's going on. So we want to ask them open-ended questions versus closed-ended questions. So what are open-ended questions?
More information other than yes or no, and the closed-ended questions are just question you and answer question.
Perfect. Yeah. Open-ended, it's a longer answer that they're required to give. Closed-ended questions are yes or no answers. Okay, so history taking techniques. So we can use OPQRST. So this acronym helps us obtain information about the current chief complaint, what's happening today, why they called us today, right? And the history of the present illness. So, onset, what was happening when this began? So, that's, I guess, pretty self-explanatory. P, provocation, does anything make it worse or better? Q, quality, what does it feel like? Is it a burning? Is it pressure, itching, etc.? Sometimes patients have a hard time verbalizing like what things actually feel like. So sometimes you can give them these kind of verbal cues to help them out in verbalizing that to you. R, so that can be region or radiation. So where is the pain? What region of the body is it in? And does it radiate or move anywhere else? So I'm sure you guys already know, but with chest pain, if someone's having a heart attack, a lot of time that pain will radiate or move down one arm or the other. Sometimes it's felt in the back, so pain radiating is something we want to look for. And then severity, so on a scale of 1 to 10, how bad is it? Patients are really bad at this question. When you ask them on a scale of 1 to 10 how bad, a lot of times they're going to tell you 14. So pain is subjective. Maybe they are at a 14, but a lot of people don't like that question very much. So, and then time. So how long has this been going on and what time did it start? Okay, so that was for our current problem, the present, what did we say? The present illness. So the next one is sample. So this is going to give us info about the patient's past medical history. So S is signs and symptoms. This kind of actually plays in as well to, the present illness, but we can ask them signs and symptoms. What's wrong? What kind of symptoms are you feeling today? Have you ever felt these symptoms before? Allergies, are you allergic to any medications or other substances? Bees, cats, environmental allergens, things like that. Medications, are you taking any medications daily? P is pertinent past medical history. Keyword being pertinent. Some patients want to tell you all of their past medical history, and it's like, that's cool, but I didn't need to know, that you stubbed your toe 5 years ago, right? L, last intake. So when's the last time you've eaten or drank some water? And then E, events leading up to the injury or illness. So what were you doing when this began? Which is kind of similar to our O and the OPQRST onset, right? So history-taking techniques for pediatric patients might have to be a little different than with our adult patients. How do you think we can alter our history-taking techniques for pediatric patients versus what we would do with an adult? Maybe using simpler words, right? Maybe getting down to their level. Sometimes asking caretakers or parents for a history is beneficial for us if they're present. We want to use simple language. School-age children might be able to describe what they feel and what happened. I fell, my knee hurts, I scraped my knee. We want to include parents, teachers, or care providers when they're available. And then we want to know if this is how the child typically presents or if this is abnormal. I'm sure you've seen sick kids before, but they're usually really lethargic and just sleepy. And so we need to ask if that's normal for them, because maybe it is, but typically it's usually not. So, okay, physical examination techniques for adults. Your physical exam can be performed before, during, or after your history taking. So you can ask all these questions before you even start your physical exam, or you can ask while you're going through the physical exam. But this past history does kind of help you tailor your assessment to your patient, right? So if they say, well, I've had a heart attack in the past and I have COPD, then we kind of know we need to hone our assessment in on cardiac, respiratory type things, right? That doesn't mean that there won't be anything else that we should assess, but those are probably the main things we want to look at. So there are 3 primary techniques of examination. We want to observe, so look at the patient to see an overall sense of their condition. We want to auscultate, so listen for sounds of an abnormal condition, so like a loud cough, abnormal breath sounds, abnormal heart tones. And then 3, we can palpate, so we can feel an area for deformities or other abnormal findings. So look, listen, feel, right? Pretty easy. On pediatrics, things are sometimes a little different. They might be more timid, a little shy. They might be scared. So we want to approach them slowly. We want to try to build a rapport with them as well. Make them our little buddy so that they're not as scared of us. So we want to start from the least invasive procedures and work towards the most invasive. Starting at the toes and working towards the head, just so they can kind of ease into this assessment, get used to you. You know, I don't know if you like it or not, but somebody just rushing straight for your head is sometimes kind of scary, right? So maybe starting down low and working up can help those peds. We want to explain all equipment to the child before we use them. And we never want to lie to a child about something that might hurt. Kids are super perceptive. I have a 7-year-old, and it's like anything you tell him, he's gonna fact check you on that. So we don't ever want to lie and tell them something's not gonna hurt when it might, right? We just have to find a better way of telling them that. And then for older children, like teenagers, they might want some privacy too. So, you know, just try to provide that for them if possible. So body system examination. So once we do our history, can kind of narrow down what body systems we might need to examine. So we base this off the chief complaint history in their presentation. So we could examine the respiratory system, cardiovascular, nervous, endocrine, GI, immune system, or musculoskeletal system. So first is the respiratory system. So the most important thing with the respiratory system is the patient breathing adequately. That kind of goes back to our primary assessment with those ABCs. Is the airway open? Is the patient breathing? That's most important. And once we determine that, then we can move further into this history and assessment. So we want to ask them if this is a respiratory issue. Do you have any existing respiratory conditions? A lot of our patients will have COPD or asthma or something that's exacerbating this problem. So we can kind of ask them if they have any of those existing conditions. We can ask what kind of medications they've been prescribed. Sometimes they'll have inhalers and things like that, treatments that they do at home. And then, do signs and symptoms of this episode match your previous episode? So that if this is something that they experience or have experienced in the past, asking if it's the same or similar to what they've experienced before is a good little key to ask to determine how you want to treat them. So respiratory physical examination, we want to look at their mental status. Why do we want to check a respiratory patient's mental status? Yep. So lack of perfusion to the brain can cause an altered mental status. We want to examine their level of respiratory distress. So is it a mild respiratory distress, or is their airway actively closing and we need to do something about it now, right? Do we see chest wall motion and accessory muscle use and/or? We want to auscultate those lung sounds. And we kind of just heard in the previous slideshow what some of those might sound like that would pique our interest. We want to look at their pulse oximetry, and we want to listen and look for edema. So do they have airway swelling? Those wet lung sounds that we listen to, those coarse and fine crackles could clue us in that there's some sort of edema there. And then fever is another thing we could look for. Okay, cardiovascular system. It can involve the heart and or the blood vessels. So for their history, again, we want to ask if they have any existing cardiac conditions and if they're on any meds for that. We want to ask about the signs and symptoms of this episode. We want a description of the chest pain. So this is one of those open-ended questions. What does your pain feel like today? And does it feel the same as it has before? Cardiovascular physical exam. We want to look for signs that the condition may be severe. So Levine's sign. What was Levine's sign? Hand over the chest, clenching the chest, right? Skin color and condition. If there's a serious cardiac issue going on, what color do you think your patient's going to be? Like ashen, there's poor circulation, maybe cyanotic, pale. And then JVD. What's JVD? Okay, cool. We want to obtain a pulse. Is it strong or is it weak or thready? Is it regular or is it irregular? We want to obtain their blood pressure. Is it low or high? Palpate the chest. Is this pain caused by a trauma or is it cardiovascular in nature? Sometimes you won't know until you palpate that, right? Maybe something happened and they are a poor historian and just haven't told you that. We want to observe their posture and breathing. Why would we look at their breathing if we think it's cardiovascular in nature? They're connected, right? Exactly. Your cardiovascular system and your respiratory system are very closely connected. Your blood, obviously, we've talked about before, circulates from the heart to the lungs, back to the heart, to the body, right? So all of that is interconnected. So yeah, again, respiratory and cardiovascular conditions are closely tied. Chest pain could also indicate respiratory issues. Okay, so next, the nervous system. So the two main elements of the nervous system exam are checking their mental status and checking for signs of dysfunction in the body. So when we're obtaining a history, we want to determine their mental status again, determine the patient's normal state of mental functioning. Sometimes we'll come on a patient and think that they're altered, but that's actually just their normal baseline, right? Maybe they've had a previous stroke and this is how they normally, how they are in normal life, right? So do they have any previous or ongoing neurologic conditions? So have they had a stroke? Have they had a TIA? What's a TIA? Perfect. Transient ischemic attack. So that's like a mini stroke, right? Do they have Lou Gehrig's disease? Anybody know what that is? ALS? I can't tell you the full, what that acronym means, but it's neurodegenerative disease, basically. We want to note the patient's speech as well. They might have aphasia going on where they can't talk. They might have slurred speech that can clue you into strokes, TIAs, things like that. So in the physical exam, we want to perform a stroke scale. If they're altered, if we suspect that there's some sort of a stroke or neuro problem going on, we want to perform a stroke scale. Have you guys talked about stroke scales at all? Not yet? Okay. We want to check their peripheral sensation and movement. How would we do that? Yeah, can you feel this? Can you wiggle your fingers? Can you wiggle your toes? Are you able to walk normally? If there's neuro problems going on, we also want to palpate the spine because spinal injuries can cause these neuro changes, right? We want to check the extremity strength as well. So one that I'll do is, can you grab both my fingers and squeeze as hard as you can? That'll show you kind of if that grip strength is normal or if there's a unilateral deficit on one side. And then we want to check their pupils for equality and reactivity, and then look at their gait as well. Endocrine system. Does anybody have questions so far? I know this is a long, boring PowerPoint. I'm sorry. Any questions about cardiovascular, respiratory, neuro?
No question about palpating.
Okay.
The longest time has been, you tell me if you're a male is palpating, a female, you got to use the back of the hands. Is that true with you guys too? Do you guys want us to do that when we ride along with you? Or?
What's your saying about the back of the hand thing? Assess, don't caress. So if you use the front of your hand, we're maybe caressing, right? But if we use the back of the hand, we're assessing that patient. So yeah, we just want to maintain that like boundary sort of. So
Same for females and males?
yeah. any opposite sex assessments, we want to do back of the hand instead.
Okay.
Was there a question over here? What's up?
So when it came to the sample, isn't it classical intake and out, ins and outs?
Yeah, that's a good point. And you're right. I didn't put that on the slide, but last intake and output, you can ask that as well, especially if it's a GI problem too. Like we want to know when they ate last and when they last had their last output, right? Okay, any other questions before we move on?
When you palpate the spine, what's the best way to palpate the spine?
So typically like the back of the hand thing is when we're looking for like priapism and things like that are in more sensitive areas, but neck and back things, you know, just feel for step off. Do we know what step off is? Yeah, like it feels like maybe a vertebrae is out of place. Do we know what crepitus is? Yeah, feels like grinding bones together. So we're looking for step off, crepitus. If we're feeling and palpating on the spine, a patient will tell us, you know, hey, that's painful. So just any pain, anything that's abnormal, right? So that's what kind of.
With medical patients, I understand, but like most trauma patients, you don't get to the back until you're flipping them over to put them on a backboard or whatever.
Mm-hmm. I mean, even if they're laying on their back, you can stick a hand under there and kind of feel the back of their neck, right? So C-spine, I mean, you might find lower back injuries later on, but that C-spine is one that's more, I mean, it's all important, but your C-spine is pretty up there, and you can feel that when they're on their back too. So does that answer the question? Or yeah, okay. Good. Okay, let's move on. Endocrine system. So the most common endocrine emergency is the diabetic patient. When we're getting that endocrine history, do you have diabetes? I ask patients that all the time. Do you have diabetes? Do you have a history of diabetes? Do you take insulin? Things like that. Diabetes can cause altered mental status, of course, so that's something we want to look for as well. What medications are you on, and are you compliant in taking them? That's a big one. Like, yeah, I'm prescribed this. Okay, well, do you take it? Well, no. When's the last time you took it? Oh, I don't know, 2 months ago. Okay, well, that's important to know for sure. Have you eaten today, or have you exerted unusual levels of energy? Is the patient sick? Have you taken your own BGL or taken insulin? And then for the physical examination, we want to again look for that mental status, skin color and condition, check their BGL, and we can look for an insulin pump. Some patients have one that they wear all day, every day, so we can look for that as well. And then again, some patients also wear medical jewelry like a bracelet or a necklace. We can look for those things. I actually have never seen that in the field, but maybe some people do. So I don't know. Okay, gastrointestinal system. We're going to look for what's gone in and what's come out. And then what it looks like when it comes out too. So for GI history, we want to ask, are you having any pain or discomfort? What is distension? Does anybody know? Distension, it's like bloated out, right? We can ask about distension or things like that. Look for distension. We want to ask about their oral intake. Do they have a history of GI issues? Is there vomiting, bowel movements? And what do those things look like, right? So we want to, in the physical exam, observe the patient's positioning. Are they hunched over and holding their stomach, or positioned in another way? We want to assess the abdomen. That would be, you know, palpate all 4 quadrants all the way across. Do you feel anything abnormal there? We want to inspect other parts of the GI system as well, which I'm not totally sure what it means by that. That's what your book said, but, you know, just, yeah. And then we want to inspect their vomitus or feces if it's available. What does hematochezia mean? Does anybody know?
Like black stool?
So that, close, but no. Bloody, right? Bright red blood in the stool. What is melena?
That's the one.
Yeah, melena is that dark black stool, okay? And then what's hematemesis? Bloody vomit, right? And if they tell you if they've done that, ask, well, is it still there? Can I go look at it, see what it looks like? If it's bright red, especially if it's vomit, it's closer up the tract, right? Because it's newer blood. Immune system. The allergic reaction is the most relevant in EMS, so anaphylaxis. So we can ask about a history of allergies. Have they been exposed to something they know they're allergic to? Have they been stung by a bee? And what are your typical reactions like? Do they have a history of asthma? Symptoms of tightness in the chest or throat? GI distress, itchiness, or rash? Medication. Do they have medications for an allergic reaction? Do they have an EpiPen? Have they taken the EpiPen? And then on the physical examination, we want to inspect the point of contact with the allergen. So if they got stung by a bee, we want to look at that, see, is it red? Is it inflamed? Is it, all those good things. Inspect the patient's skin for rashes or hives. We want to inspect the face, lips, and mouth for swelling, and that's a big one too, because that airway, especially, when it starts forming anaphylaxis, that airway will close up really quickly on you. Then we want to listen to the patient speak. If they're kind of like slurry or jarbled or whatever, that airway might be compromised. Then we want to listen to their lung sounds to ensure adequate breathing. Okay, musculoskeletal system. We're getting close to the end. Y'all are doing great. So medical diseases in this system are rare. Most musculoskeletal examinations will be performed when there's trauma, right? So typically medical is not most musculoskeletal related. But in the history, we want to ask about prior injuries. Is the patient taking blood thinners? Are there underlying diseases or conditions that make fractures more common for them? We want to see if there's a history of a medical problem that caused this traumatic injury. So, were they doing something, passed out, wrecked their car, and now they have a traumatic injury? Like, what's that medical reason, right? So in the physical exam, we want to inspect for signs of injury, such as deformity. So in the C-spine, we talked about that step off, crepitus, things like that. We want to palpate areas with suspected injury, compare sides for symmetry. And we just talked about crepitation, so there's that. And then in traumas, we want to assess our patient head to toe if there's multiple injuries or if the patient's unresponsive and we don't know why. Okay, so this part of the book really irritated me. So it talks about diagnosing your patients towards the end of the chapter. In your book, it says that you can diagnose, okay? I think it says that we do make diagnoses. So for testing purposes, cool, fine. But when we're in the field, we don't diagnose patients, ever. In real life, we don't diagnose patients. We don't want to tell a patient what our diagnosis is. We can inform them of what might be going on, and that would be called our differential diagnoses, but we don't ever want to tell them a diagnosis. We need to let them know that they'll need further testing and definitive care to be formally diagnosed. So what is a differential diagnosis? Different possibilities, right? Yep. Differential diagnoses help us think about what might be going on with our patient and help guide us towards what assessments we might want to perform. We can rule out differential diagnoses through assessment to get a narrower view of what might be causing the patient's symptoms. Okay, any questions on any of that so far? I think there's 2 or 3 more slides, so we're just about done. So shortcuts and biases. So a lot of clinicians over time come up with shortcuts to diagnose patients. Hey, I've seen a patient that looks like this before, so this is probably what's happening with them, right? Just making those assumptions based on what we've seen in the past. And that's called heuristics. So those shortcuts to diagnose patients. But these shortcuts do have their limitations. Sometimes it's good. Sometimes we can say, hey, I've seen a patient with anaphylaxis. I see this patient, their throat's swelling up. They have a bee sting on their arm. This is probably an anaphylactic reaction. But sometimes a condition might look like one thing and turn out to be something completely different. So we don't want these shortcuts to lead us down the wrong path away from what the actual problem may be. So some of these limitations to the shortcuts: representativeness. is using certain signs and symptoms that resemble a particular condition. You might assume the patient has that condition. So that's like what we just talked about. Hey, I've seen a patient that looks like this before, and so that's probably what it is. And then we stop there. We stop thinking about different diagnoses at that point. Availability is the urge to think of things because they're more easily recalled. So let's say you just went on a patient that was having a heart attack and you get called to another patient with chest pain. Because we just had that patient that was having a heart attack, it might be easy to think, oh, another heart attack, because we just saw that. We were just thinking about that, when in reality, it could be something totally different. Overconfidence. So thinking you know more than you really do can lead to problems. Has anybody heard of the Dunning-Kruger effect?
You had to learn before your career in EMS is over.
Yeah.
Because you're gonna like still tell them all the way through this class, and then you're gonna get done with it. You're gonna pass, and you're like, I know everything.
Mm-hmm.
And then
Yeah.
there's gonna be a call that you run that absolutely kicks you in your hole. And you'd be like, I am an absolute idiot, and it's gonna go.
Yeah. So that definition of overconfidence is basically the Dunning-Kruger effect. It's thinking you're smarter than you are, with having limited knowledge. So it's just important to know, like, yes, I know some things, but I don't know everything, right? Confirmation bias. So that is looking for evidence that supports the diagnosis you already have in mind. So I go on a chest pain patient, I think it's a heart attack. I'm going to look for evidence that's going to support my own diagnosis, when in reality, that might be the wrong diagnosis altogether. Illusory correlation. So that's correlating to events that may appear connected when they're really not. And then anchoring and adjustment, clinging to your initial hypothesis, even though evidence suggests that your hypothesis is wrong. And search satisfying. So determining the cause of a patient's problem and then stopping the search. So you might think it's a heart attack. You perform some interventions and some assessments. You determine it isn't a heart attack. But what if there's something else going on with the patient as well? We don't want to stop our search just because we think we found the cause. We want to continue going, because a lot of these patients do have multiple things wrong with them. So then learning to think like an experienced clinician. So we have to learn to love ambiguity. Nothing in EMS is textbook. Everything is kind of unknown until we get to the scene and assess for ourselves. That was one of the things that was really hard for me. I'm like a list person. I'm like, we get there, we do this and this and this and this, but that's not how this field works, unfortunately. We need to understand the limitations of technology and people. We need to realize that no one strategy works for everything. Again, that goes back to, me. I want that list. This is the way we do things every time, and it doesn't work that way every time. We need to form a strong foundation of knowledge. So that's your opportunities now while you're in this class. Of course, you continue learning once class is over, but having that strong foundation really gives you some confidence in the field as well. Organize the date in your head. That must be, the data, excuse me, another typo. We want to organize the data in our head, okay? Change the way we think, learn from others. That's a big one. That goes back to the Dunning-Kruger thing, like, you're not the smartest person in EMS. I'm not the smartest person. None of us are the smartest people. So learning from each other is a big, big thing in this field. And then reflecting on what we've learned. So if you go on a call where you had some questions, you were a little unsure, coming back and debriefing that is important to continue learning in this field. Any questions? That was long, I'm sorry. Any questions? No? Okay.
Learning from other things. Some people are really arrogant on the field.
Mm-hmm.
And you're not supposed to show that sign in front of patients.
Yeah. There's a lot of type A people in EMS, and strong personalities, and sometimes that's a hard thing to navigate. But yeah, we try not to be that way. Just try to be humble. We don't know everything. None of us do. So. Yep.
No, we all make mistakes. We all learn from them.
Yep,
The best ways to learn lessons in this job is learn them the hard way.
Mm-hmm.
And I say that as respectfully and as nicely as I can. You're going to run calls in this. You're going to frick them up. You're going to absolutely make the wrong decisions. I've done it. Becca's done it.
Hannah's done it. But those are going to be the lessons that you take back home, and you're like, all right, well, I'm not doing that again because that was dumb. The thing about medicine is it's an ever evolving process. Everything that you're learning now, 10 years from now, is going to be completely different than what that EMT class is going to learn. Every learned at paramedic school is going to be completely different in 10 years. We're learning, if you go back 10 years ago, dopamine was the best thing in the world. You gave dopamine for everything, and now we don't use dopamine for anything. Mm-hmm. So medicine is ever evolving, and you're always trying to learn. So if you ever believe that you know everything, it's time to just sit down and jump back and move on with your life, because you're going to kill the crap out of somebody, and then you got to go home and live with that too. So.
Mm-hmm. All right. If you guys want to take a quick break, 5-minute break, if anybody needs to go to the bathroom or anything, we're going to start on the secondary assessment.
And chapter 16 is super short, so don't worry.
We're just going to power through it, so whenever we get to the really long chapters, we don't keep you so long.
Beautiful. Thank you. If you haven't given me your drug cards, I will be putting grades in the computer sometime this weekend. So make sure I get them before you leave. If you did them. If you didn't, you get a 0.
I'm just going to move this in. We won't need him in here until like kind of towards the end of it. But if we just move it in, we won't have to worry about it later.
Stretcher.
Scratcher. I guess that's what they keep saying. I don't know.
Stretcher.
It's got a brand new battery in it too.
Sounds like it needs a wheelbarrow.
Let me make sure this is a good position.
You said what now? What about them? Oh, the trauma and the medical? Yeah. Yeah, we'll
Left
give
leg.
you.
Listen, this bed's built for
Do you
speed,
have,
not for comfort.
Jonathan wasn't here for the trauma when you handed out the trauma and medical assessment sheets?
They're all on Mike's desk.
Okay.
Okay, just make sure. We found out earlier that they don't say advanced right here. The ones we handed you should be good, but
yeah, the trauma and medical assessments.
ping ping. Just waiting for one.
So we're going to power through some of this stuff, and then we're going to show you kind of how the rapid trauma assessment works, how fluently, how quickly. I'm going to kind of talk you through it.
Yeah. So if you guys have your sheets with you, we're going to be going over this secondary assessment part. And like Mike was saying, whenever you look at these, they are the same up until like this part right here. So we're going to be talking a little bit about the differences between your medical and your trauma forms today. We're going to show you a rapid trauma assessment. We're going to do it slowly so you guys can observe, and then we're going to do it in real time. And we want you to be able to do it in real time by the time you're done practicing. So as we do like these Saturday classes and like the practice whenever we go out there, you guys can go ahead and start slow and make sure you're hitting everything, but then you're going to start to speed up, because whenever we're on scene of like a trauma patient especially, we don't want to be on scene forever, right? Because what do they need ultimately most of the time? A surgeon. And I am not a surgeon, unfortunately. They make a lot more money, I'm sure.
A good way to learn these, though, is just do it on friends, family, coworkers, whoever you're practicing this stuff with. Just go through, hand them the sheet, or you look at the sheet and go through it over and over and over again. Just read through it, do it, read through it, do it, right? And then once you get to the point that you can set this off to the side and read this off and go through it and do it, then you've got it. And
that's what you need.
And the
because-
easiest way for most is putting it in those blocks, so memorizing it by block.
Yeah.
Also in class, we're going to do like a thing where we have something to throw around the room and we're just going to go down. Not today. We won't have time today. We're just going to go down the list, and then whoever messes up, you start over from the beginning until we all get it memorized, because it's important, especially for that national registry test, because that's how they word those questions. You guys may have seen a few questions already that are worded funky because of those. So objectives of our secondary assessment, we're going to review points in that secondary assessment on your sheet. So if you have it, if you want to follow along, awesome. If not, just keep it with you. It's your new little Bible because you're going to memorize it. You're going to identify when to reassess specific patients. So we have stable, we have unstable, we have trauma, we have medical, and we're going to talk about when to reassess these patients. And then we're going to learn our acronyms.
You
I
need
wrote
to
them
know
down.
these acronyms.
Yes, these acronyms are very important. I suggest you start studying them like last week. Get them memorized, learn what they all stand for, because there's a few test questions that are they're pertaining to those acronyms.
And if you look at me and you say that I'm checking for DCAT BTLS, I'm going to ask you what that means.
Mm-hmm.
So don't say it if you don't know what it means, because then you're going to be looking goofy when you look at me funny.
Usually if you're like doing an assessment and you're like, I'm looking for, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling, I'm not going to expect you to say it like that every single time. Just tell me you know what it means, and then as you go down, DCAT BTLS, DCAT BTLS. Does that make sense? All right, so we have 3 categories of patients. We have the medical patient. So what's an example of a medical patient? Chest pain, heart attack, difficulty breathing. Psych patients are medical patients. We have trauma patients. That one's pretty self-explanatory. Somebody ran their car into something. Somebody stubbed their pinky toe. That's a trauma patient. You can have medical and trauma together. So someone had a heart attack, then crashed their car into the tree. That's a medical and trauma patient. Then we have the unknowns. You get toned out for an unknown whatever. You don't really know what's going on until you get there. Sometimes you still don't really even know after you've done your full assessment. 3 basic components of the secondary assessment. So we have our physical exam. We're putting our hands on these patients. We're looking at the patients, right? Hannah did a good job on touching on look, listen, and feel. Those are the 3 main things that we're going to be looking at here. We have our patient history. If you can obtain a history, do your best to obtain that history, whether it's looking at their medicine. It's always a good idea to kind of get an idea of what different medications are prescribed for certain things. So like if someone tells me, or I find a bottle of metformin and this guy's unresponsive, what might that clue me in on? Diabetes, yeah. And then we're going to take our vital signs, right? We have all been practicing vital signs. If you guys want to start implementing that palpate blood pressure, that's awesome too. I have utilized that a lot when I can't hear it and I'm like, okay, but I can kind of feel it. Also, whenever we're performing interventions that are affecting the blood pressure, that's a quick and easy way to be like, okay, it's going up or it's going down. So your physical examination, this starts out, sign is something that you can see. So me looking at Chaz and his face is flushed, that's a sign, right? A symptom is him being like, yeah, I've had a fever for the last 3 days. That's a symptom. So he's telling me what's going on. We have our history of present illness that we've obtained, right? So we've all talked about HPI. We just went over it with Miss Hannah over here. So we're going to be using our sample history, right? So signs and symptoms, allergies, medications, past medical history, last oral intake and output, and then our events leading up to, right? Again, we're going to harp on these open-ended questions. Can somebody give me an example of an open-ended question?
Can you tell me more about
Good. So she said, can you tell me more about how you hurt your ankle? That's an open-ended question. That kind of lets me answer the question instead of, do you have pain? Yes. Where's it at? Here. That's closed, right? We want them to be able to tell us what's going on. There's a really good podcast out there that I like to implement whenever I'm running calls. It's called Listening in Color by Ginger Locke. I don't know if anybody has heard of her. Whenever you're asking a patient what's going on and you have time, let them finish their story, because we are really impatient people and we like to walk in and be like, so what's going on today? And they start to tell me and I'm like, cool, that's all I need to know. Let's go. That is so easy to do. So it really only takes a minute and a half of them listening on average. So ask those questions, listen to their story, because you might get more out of their story than you think, right? What vital signs are we going to get on every patient? Respiratory rate. What else? Blood pressure. Cool. Heart rate. SpO2. Eyes. Skin color, temperature, condition. Yeah, good job. So again, like Hannah said, it's also important to know that your initial set of vitals is important because it gives us a trend. So you get that initial set of vitals. By the time you're transporting or at the hospital, is that patient getting better? Are they getting worse? Do you need to do something different? This is important on every patient, right? I put BGL if indicated here because in EMS they love to be like, take a BGL on everybody. If grandma stubbed her toe, unless she's altered, I'm not going to do a BGL on her. Like, we have to think about our patients too. We charge for that, right? So like, am I going to do an unnecessary intervention? That's just my thought. Some other people might have other thoughts about it, but that's just who I am as a person. So any kind of neurological symptoms, problems, BGL. Then we have our reassessment. So these numbers are important to know. So if your patient is unstable, what would be an example of an unstable patient? Heart attack, chest pain. Chest pain is unstable. Did I hear? Yeah, abnormal baseline, multi-system trauma. So your unstable patients, if you look at this patient in your initial assessment and you look at them and say they're sick, remember that sick or not sick, we need to go. That's an unstable patient. 15 minutes for a stable patient. If they're stable, they're chilling, they don't have chest pain, they're like, yeah, I've thrown up once today, all their vitals are perfect. That's every 15 minutes we're going to reassess. And then every 10 minutes for the trauma patient. So any kind of trauma, like especially higher mechanism of injury, we're going to do 10 minutes or less if they're unstable trauma patients, 5 minutes, right? Okay, so if this secondary assessment part of the medical patient, so if you have both sheets, you can this is where it starts to get a little bit different. All right. So we look at our history taking, right? So this is where that OPQRST comes in. You can see that it's a little bit different than on your trauma sheets. So whenever we're talking about the medical patient, a lot of times they can answer our questions if they're responsive, obviously. So this is where we bring in that OPQRST. This is where that sheet differs from medical to trauma. So we're going to do the OPQRST and the sample questions. Look around the scene for clues, medication bottles. That's a big thing. Any bystanders or family members that are on scene that might be able to clue you in on what's going on, that's very, very helpful. So we have our different systems, right? We're going to reassess assess the different systems. I'm not saying that you have to assess these systems on every single patient that you have, but if somebody calls for chest pain, I like to teach to try and assess at least 4 to 5 of those symptoms, because they might, it might be a cardiovascular issue. Like Hannah was saying, it might be a pulmonary issue, right? It could be an allergic reaction causing their chest pain. It could be so many different things. So we kind of want to keep our scope like broad. So whenever we're assessing these patients, you don't get that tunnel vision. You're like, it's heart attack, it's heart attack, it's a heart attack, it's a heart attack, but they actually just swallowed a bottle cap funky, right? So we have cardiovascular, we have our pulmonary. What are some questions that you could ask or something that you could assess that relates to the pulmonary system? Their lungs, yeah. Listen to lungs. What else?
There's a big one. There's a big one that people don't think about too.
Chest rise and fall.
Chest rise and fall, sounds, lung sounds.
What's the big one are you thinking? Yeah.
Edema.
Oh, edema, pulmonary edema. What about neurological? How are we going to assess neurological? Mental status, good. Pupils, good. CSM, yeah. What about the musculoskeletal system? What are we going to look at or maybe ask about? DCAP, BTLS, deformities. Yep. What about the integumentary system? Yep. Condition, skin color, temperature, condition. Do they have any rashes going on? Are they discolored in any way, shape, or form? Are they purple from the nipple lines up? That's a bad sign. What about the GI system? What can you ask? Ins and outs. Good. Have you been eating normally? Have you been pooping normally? I love to tell people, I know we just met and this is awkward, but what did your poop look like today? What about the reproductive system? Yep. Pregnancy is a big one. If they could be pregnant, if they're on any forms of birth control, that can kind of tell you about some other things that might be going on. Psychological or social. What about that? What question could we ask that relates? You can ask about where they're at. A big one for this is kind of like if I have a chest pain patient and I'm assessing like a psychological or social, you could do like ask them where they're at or whatever. But I like to ask them about like, hey, have you been like extremely stressed lately? Do you have any history of anxiety? Do you have any history of schizophrenia? Especially if someone's like talking to me a little bit crazy, but not crazy enough that I can put them on that scale yet. Those are good questions to ask. So we want to ask information that we feel like can be tailored to their chief complaint, right? So if someone has a stub toe and I'm like, have you had chest pain today though? Like that's kind of a funky question to ask, right? It's not really tailored to what's going on with them. Something that like, hey, you fell. Were you dizzy before you fell? Were you having, shortness of breath at all? If you are watching your patient and they're kind of like struggling to breathe and they're like trying to walk around on the little walker, like ask questions that pertain to that patient specifically. So example, chest pain. Do you have a history of heart problems? What medications do you take for your heart, if they take any? All right, OPQRST, right? We know this. I'm going to get my cup of doom out because I like it.
Dun, dun, dun.
Carly, didn't I pull you last time? How would you ask about onset? I'm your patient. I have chest pain. What are you going to ask me? Good. So when did this start? Oh, it started about 2 hours ago. All right. Garrett. You walk up to me and you say, what provokes your chest pain? And I look at you and I say, I don't know what that means. How are you going to ask that question?
What were you doing when it happened?
That's going to be more towards like the onset kind of thing. Anyone want to help him out? Yeah, what makes it worse or better? So when I sit down, my chest pain goes away. And when I get up and walk around and try to mow my lawn, it makes it worse. All right. Alex? What about quality? What are you going to ask me? My chest hurts real bad. Does anyone want to help him out? Good. Describe your pain for me. Is it dull? Is it sharp? Does it feel like an elephant sitting on your chest? That's a big one. All right. Let me get here. All right. Nick?
Radiate.
Yeah.
So does it hurt up here? Is it hurting over here as well? Is it going to radiated pain?
Yeah.
A good way to ask them is just, does your pain move anywhere else, or is it just in your chest, right? Because you don't want to point them in a direction. You don't want to say, does your pain hurt in your left arm? Because then a lot of people would be like, yeah, absolutely it does, right? So ask them, like, does your pain move anywhere?
Yeah.
Are you hurting anywhere else other than your chest?
Hmm. A perfect example of that is I had a patient that would, like, you'd kind of lead her the right, like, a way, like, hey, is your pain sharp? Yeah. Is it dull? Yeah. And then I asked her, I was like, does it burn behind your eyes when you pee? And she goes, yeah. So just kind of like avoid
directing them
yeah.
towards their
Oh.
situation.
All right. Emily.
Oh,
She's
Emily's in Austin.
I had to think about that one for a second.
Emily.
Can y'all unmute yourselves? I pulled Emily's name. Is Emily there today? I guess that would be the first question.
It brought up all your answers.
Oh no. Oh no. Don't look.
We wrote them down like
I don't know if Mhm. I don't know. Did they unmute themselves?
I don't know if they did. They should be coming through the.
Okay. All right. Well, we can just try another name if their little audio thing's not working. This is cheating, Liam, because I know you saw the answer. But how are you going to ask me about severity?
It's
Yes.
always 15.
It's always
It's
15.
never changes. It's always 15.
And then you re-ask them. 1 is no pain. 10 is you're on fire, being eaten by alligators. And then they're like, oh, it's a 3. So, all right. For kids, one thing you can do to kind of tailor this to kids is, like, I'm going to try and explain this the best way I can. I ask them about pieces of hurt. And I know that sounds really confusing, but I'll take something like quarters or something and say, this hurts the most. And I have 5 quarters in my hand. And I'll ask them, how much does yours hurt? And they'll take the quarters. And then that kind of is like a visual representation for kiddos, just a little bit easier. Give the answer away again. Matt. He's also in Austin.
He is.
Christian.
How long and when did it start?
Yeah. So it started about 2 hours ago. Another question I like to ask about time is, like, have you ever felt this before? Like, how long have you been dealing with these kinds of problems? That kind of relates the same way. All right, good. So our physical exam for the medical patient, it's brief. We're talking about things that relate to their chief complaint. So remember that your dispatch information and your chief complaint can be 2 totally different things. So you can get toned out to leg pain and you get there and they're shot in the belly button. Okay, so they're not always the same. Chief complaint is what the patient is telling you is wrong with them today. So you can observe shortness of breath, but if they have a headache and they're like, man, my headache hurts, my headache. Headache is their chief complaint. You can observe shortness of breath. Would that be a sign or a symptom? The shortness of breath. The sign, right? And their symptom would be what? The headache. Good. Okay. So then, as we move down our little sheet, we're going to administer our interventions, whatever they may be, appropriate to that patient, and then we're going to transport. Yeah. All right, so another pediatric note, Hannah talked about this a little bit. This chapter is very redundant. All these chapters tonight are very redundant to themselves, but get on that same level as a kid. Like Hannah said, you don't want to go walking up like, hey kid, what's going on? They're scared. Put them in simple language, your questions. So make it easy for them to understand, kind of get on their level, right? Parents are going to help you. All right, so we start our assessment with an unresponsive medical patient by doing what?
What's the first thing you do?
BSIC safe.
safe. I like it.
You called
All
me
right,
an
your
ALS.
scene is
Okay.
safe and you have on your stuff.
Good, I like it.
Yeah.
Pulse, right?
Pulse,
So we go
right?
CAB. All right, if you can assess, if you can ask questions, if you can get questions answered by bystanders or relatives, that's helpful. If not, don't like completely go out of your way and avoid treating this patient trying to get answers. Because if this person's sitting here not breathing and I'm like, where's your aunt? I need to go find these answers. They're just it's not good for them, right? So rapid assessment of the entire body. We're going to do a head to toe. So this is going to be very similar to our trauma assessment that we're going to walk you through tonight. We're going to do a head to toe. We're going to look around. We're going to look at the ground. Are they laying on carpet? Are they laying on hardwood floor? Do they have a big old bruise on their forehead? Are they cool, pale, diaphoretic? These kind of things we're just going to go through real quick. So, rapid physical exam, head to toe. What is CMS? Yep. Circulation, motor, sensation. So, I have it in here somewhere. We'll talk about it a little bit more later. Same kind of thing Hannah was talking about. Look for JVD, look for medical devices. I've seen one patient probably in the last couple years that actually has a medical device. And she wasn't even wearing it last time I went on her, and I knew she had it. Breath sounds, distension, firmness, rigidity, those kinds of things.
What
Pelvis.
is distension?
Bloating.
That's like bloating, right? That hard, kind of distended abdomen. I only say that for a reason. So.
Mm-hmm. And then we have incontinence. What is incontinence?
Can't hold your bladder.
Yeah, can't hold your bladder, can't hold your bowel. You're incontinent. If you need ALS, you should have, there's a spot way up at the top of the sheet that you can request them. Don't be like, hey, I'm on my secondary assessment and I realized just now I need ALS, but I can't now because I'm on the second part of my assessment. If you need ALS, get them rolling your way. All right, so our secondary assessment of our trauma patient. This is where Calvin comes in. Yeah. So this, like we said, this is where on these sheets where it differs from one to the other. So we're going to have injuries. Obviously, the severity can range, right? So you can have somebody that is from this accident, or you can have somebody from a fender bender where the dust didn't even get knocked off their.
Don't do that again. Already been through this once.
So make sure you're keeping this in mind whenever you're doing your secondary assessment to know what injury patterns to look for, right? Like we talked about on Tuesday, if somebody gets T-boned, what does that do to our body? Good. So our body moves and our head stays, right? If someone goes head on and they go up over their steering wheel, we're going to look for certain injury patterns. If they're going to go up under, I said up under, up over or up under the steering wheel. There's one of my small strokes. We're going to look for injury patterns, all right? So if they're awake talking to you, like they stubbed their toe here, we're going to ask them about that specific area. Like, hey, Calvin, you stubbed your toe. Can you tell me about what happened today?
I was walking and I kicked the dresser on accident.
Dang, that was Calvin's
Martha
toe.
put it in the way of the door.
All right, so I'm going to assess this area.
Freaking picture.
Right? So ask those questions. What were you doing when it started? Were you running? Because that makes a difference when you're running and kick your toe, right? Even though it's something so simple, it's good to get this information. History, if you can try and obtain it, go ahead and try. A lot of times with trauma patients, if they're unresponsive, you don't really get that history taking, but there's still a point that you get on that sheet if you attempt. So if you just say, I'm going to attempt to get a history. All right, so we're going to look, listen, and feel. So I'm just going to walk you through, right, a rapid trauma assessment. We're going to go kind of slow, and then Chaz is going to show you.
BSI scene safe.
Yes, it is. Your scene is safe. So we're going to start with the head, right? By this point in the secondary assessment, any major bleeding should have been stopped, correct? Okay. So this part is where we assess, we secondary assess, and we treat any other injuries that are maybe not life-threatening. There is a possibility that you do your initial assessment, and as you're doing your secondary assessment, you look at it and say, oh, that's life-threatening. Let me fix that. So rapid trauma assessment, you start at the head, right? We're going to palpate the head. Whenever you palpate somebody's head, don't go digging your little fingers into their skull.
Especially if you feel something. Like if I touch him on top of his head right here and it goes whoop, I'm not going to do that again.
Yeah.
All right? Don't be like, dang, that's not supposed to do that.
Yeah.
Just let it go. It's all right. There's
Yeah.
nothing you can do about it.
Use the flat part of your fingers to assess somebody's head. If you have a kiddo with fontanelles, right, don't go poking on the fontanelle, please. It looks bad. It's bad for them. All right, so while we're at the head, we're going to look into the ears. Okay, you're going to look for any drainage. You're going to look for any bruising behind the ears. Does anybody know what that's called? It is battle sign. Good job. So that tells us that there's a skull fracture, usually, right? And normally it doesn't show up till later, but we still want to assess it on our patients. We're going to look at their eyeballs, okay? Are their pupils equal, reactive, round, and then are they
It's when
accommodating?
your little flashlight comes in, right? You pull your little flashlight out or whatever, and you run it across their eyes real quick, wham, done.
Okay, and then are they accommodating? So if I cover one eye and I shine a light in this eye, this pupil should also constrict. So are they working together? Do I have one that's sluggish and one that's normal? Okay, those are things to look for. Does he have any drainage coming from his eyes? Does he have any drainage coming from his nose? In his airway, is he talking to you? If you haven't already solved an airway problem like bleeding into the airway, now would be the time to do it. So
That's because you're sleepy.
yeah, you're going to feel, right? We're going to palpate our zygomatic bones, so our little cheekbones. Does everything look symmetrical? We're going to look, listen, and feel. Okay. As we do that, we're going to move down to the neck. So whenever we're looking at the neck, he's just choking him out.
I was checking tracheal placement.
So we are going to look for tracheal deviation, right? So they say look for tracheal deviation. The times I've seen it, I've never actually seen it. I feel it more before I see it. Unless it's a teeny tiny little person, you're not going to see tracheal deviation. So you actually feel. So you feel as their trachea midline, you want it to be going down the middle. What does it tell you whenever their trachea is like this? Plant to the side, one side or the other. Collapsed lung, exactly.
That means I get my big needle out and stab Calvin in the chest for a second time.
All right, so tracheal deviation, JVD. We're going to look at these neck veins right here. So if the neck veins are bulging out, right, that's JVD. There's increased pressure in the chest. If they're flat, like abnormally flat, like if they look like little valleys, that's telling you that they're probably bleeding into their chest. That's where the difference comes in, because you can have a hemothorax with blood in their chest, veins flat, pneumo, veins out. Okay, so he checked his neck. He's going to move down to his chest.
Check the back of his neck.
Oh, yeah,
too.
check the back of his neck too.
Make sure you don't feel any step-offs, deformities. If you feel something that feels like it's scraping against something else, don't touch it again.
Mm-hmm.
All right.
Yep. So we're going to go down the chest. He's going to palpate the collarbones, right? This is okay to palpate with your fingers. Whenever we're talking about like the assessed ticklish, make sure they're symmetrical, right? Because we're symmetrical people most of the time. So palpate those clavicles, palpate that chest. If you get down to the breast area and it's a female, use back your hand, okay?
Back of your hands keeps you out of jail.
Yes. Another thing I like to do when I'm at their chest is I actually bring my thumbs together on their sternum and have them take a deep breath in. If my thumbs move together, that's equal chest rise and fall. If it's a trauma patient and they have unilateral problems and they go to take a deep breath in, my thumbs will disconnect. So that tells me that it's not equal chest rise and fall, right? All right, so we're going to feel those ribs, the ribby bibbies. Okay, feel down the sternum with the side of your hand. You want to make sure that's stable, right?
Now watch for your bullet.
Good. Listen to lung sounds while you're there. Good job. I will say, whenever we're listening to lung sounds, the most effective place to listen to lung sounds is stethoscope to skin, on the back, and when the patient has their mouth open. Is that plausible in every situation? No. But if you can get to that point, please tell your patient, take a deep breath in through your mouth, put it on their back. If it's a trauma patient that we're keeping on their back, you don't have to do all that. But stethoscope to skin is ideal. You're going to hear it the best. Now we're going to move down to the belly, right? So we're going to palpate. If that patient is having pain in a certain area of their belly, you're going to start at the furthest point away, because you don't want to be yanked right where they hurt, because they're not going to want you to palpate anymore. So as we're palpating, we're actually trying to feel. I've seen so many times, and I used to do it too, so I can't even talk that much crap. Whenever somebody goes to palpate, they're like, right? That's not palpating. We're going to actually palpate and feel. Sorry, Calvin. We're going to actually palpate and feel. I'm sorry.
Like Lake said, he worked hard to heal those wounds.
I'm sorry. I didn't realize I poked you that hard. All right, so we're going to actually palpate, right? So feel for that distension, feel for that rigidity. Look at their stomach. Do they have any crazy bruising? Do they have any kind of scrapes, anything like that going on? Rebound tenderness. Yes, what does that indicate?
Did that hurt?
It could be bleeding, but there's a big medical one that causes rebound tenderness.
Wham!
Right lower quadrant normally. Appendicitis. Yep.
Wham!
Okay, so then we got to move down to the pelvis. We're going to do a pelvic sweep, right? Back of the hand. We're
Back of the
assessing
hand.
for priapism.
Yeah.
Okay, what is priapism? It is a sad
It's
bone.
sad boner.
That's exactly what it is. So
check
back of the
Calvin.
hand, we're going to sweep. We're going to check for that. Okay, we're going to look for incontinence, right? And then we're going to feel. So we used to teach that you come in and you
press real
rock the hips, like you press down, and if it feels stable, then you put your hands like on their hip bones here and push down. We don't do that anymore. Why not? Yeah, we're going to cause more damage, right? If there's like broken things in there, it's going to shift and cause more bleeding.
And you can bleed out in your pelvis. You can lose enough blood out of your pelvis, dead.
Yeah.
So if it moves and it's not supposed to, don't touch it no more.
Yep. All right, so after the pelvis, we're going to come down to the legs, right? We're going to do extremities. So whenever you're checking stability of leg bones, you're going to actually, unless you see an obvious deformity, don't go cranking, right? But we're going to give opposite pressure on one bone. So we're going to push inside, inside, and actually feel. Okay, does that make sense? Like this. If there's like an obvious deformity, don't go doing that, please. Fix the problem. We're going to do that here. We're going to go down. Same thing here. It's stable. We're going to check CMS. So we're going to check circulation, feel for his pulse, whatever pulse you want to feel here. I like to take a Sharpie and mark it with an X, because if I find it once, it's going to be easier for me to find it again, because it's always really embarrassing when you're like, guys, where's a pulse? And then you can't find it.
Especially if they have a broken extremity, you need to check these pulses.
Mm-hmm.
Especially if they have a broken extremity, because if you've lost pulses in this extremity and they have a broken leg, in some degree or another, and you go down here and you can't find a pulse, that's a problem.
Mm-hmm.
And they need to be out of here really, really fast instead of just kind of fast, right? So make sure you're checking this, especially on broken. Same thing with the arms.
Mm-hmm.
Check for pulses.
Yeah. So then motor. Hey, Calvin, can you wiggle your toes for me? Awesome. Can you push down like you're driving a car? Awesome. Pull up. Awesome. Good job. All right. And then for like sensation, or like, that's the word.
Yep.
Okay. Words are hard today. I'm going to find a big toe or a little toe. If you choose a middle toe, same thing with fingers, they never know which one you're actually touching, right? So they know big toe and they know little toe. So I'm going to find a toe and say, hey, what toe am I touching? Good job. What toe am I touching? Awesome. You can also do like, hey, am I pinching you or scratching you? Okay. So then we're going to do the same thing to the arm. We're going to move up to the arms, do the same thing. We're going to feel those little bones.
This is familiar.
Check
No,
CMS.
last time it was like this. And on the other side.
Check CMS. Check
Oh.
CMS.
Sorry. We're going to check the finger. All right. Okay, can you wiggle all your fingers, buddy? Oh, okay. All right. Cool, cool. Can you squeeze that finger real nice and tight? Beautiful.
Perfect.
Dick.
All right. And then right about here is, if you haven't already, we're going to check the back. So usually this is best done whenever you're like rolling them to get them onto like a sheet, or maybe like something to help you get them onto the stretcher, like a backboard or a scoop stretcher or something like that. As you roll them, you're going to feel down their back. You're going to feel down their spine.
You're just going to run your fingers like this.
Run your fingers right down the spine. And then you can do another sweep and look for any blood or incontinence. You
Don't
hopefully
stick your
have
finger in
gloves
nobody's
on.
butt.
We don't check rectal tones. Okay.
But you're not.
If you ever hear your EMT
No
or
blood, good
paramedic
tone.
spit on their finger, it's time to leave. All right, so Chaz is going to do one in real time. So that was slowed down. We kind of talked you through everything.
I may or may not miss something that's directly on y'all sheet, just because I kind of subconsciously do it in my head. So I'm going to try to hit everything on y'all sheet.
All right, so scene safe.
BSI scene
Airway
safe.
breathing C's controlled. You're good.
All right, we're going to consider C-spine precautions, right? I'm going to check his head. As I'm coming down here, I'm going to look inside of his ears, check behind his ears. I'm going to check his eyes, pop his eyeballs open, check with a flashlight, check with a flashlight, check his nose, check his face. You say, ah? Yeah, check his airway, right? Because he's conscious. So we're going to check his airway. Sorry, I'm about to spit stuff on you. We're going to check the back of his neck, check for any crepitus. We're going to check collarbones, right? Check shoulders, make sure everything's good. I'm going to palpate down his chest. Like Becca said, you can take and run your thumbs, take a deep breath. Beautiful. Everything's good there. Are you hurting in your abdomen anywhere? I'm not going to press him down
He does
super
now
hard.
because I freaking
Him's abdomen is a little tendy,
So
okay?
sorry.
If y'all don't know Calvin, him's had an accident, abdomen a little tendy, so we're not going to press on him super hard. But I'm going to check that, right? Come down here, small palpations, right? We're not pushing in, right? Check the old pee-pee. We're going to come down here. We're going to check extremities, right? PMS in this leg. Can you feel that? Which toe am I touching? All right, press against me. Pull against me. Same thing. Check this leg. PMS. Which toe am I touching? Press against me. Pull against me. Beautiful. Go up here. Check extremities. Make sure he's got a good pulse. Beautiful. Squeeze my hand. Can you wiggle all your fingers? Beautiful. Check PMS in that arm. Come over here. Same thing. Check for a pulse. Beautiful. Squeeze my hand. Beautiful. Wiggle all your fingers. Check there. And then we're going to roll him, right? When you grab to roll somebody in these situations, you have somebody holding manual C-spine. If you got a C-collar on them by now, shoulder, hip. If you have more people, that's great. If you don't, that's how you're going to grab, and you're going to roll them. When you roll them, same thing. You're just going to run your hand down their spine, just kind of fingers down the spine. You can check his butt. Don't stick your finger in the butt if you feel any crepitus. So what do you think that we're trying to accomplish in that process? Do you see how fast that happened? Right? Like it's a very just like tap, 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 top to bottom.
Yep.
So you're looking for secondary injuries, right? Because if I walk up and Calvin here has a bone sticking out of his arm and he's squirting blood all over the place, right? That's going to be something that I address immediately, right? Everything else that I'm going through, if I come in and I look at the back of his ears and he's got vital signs, noted. That's all you can do about it. Noted, right? If I come down here and he's got a big old bruise on his chest as EMT basics, noted, right? If I come down here and he's got a broken leg, noted, right? Because hopefully you have, some sort of support coming if you're not riding with a medic. But your big thing is just to identify all these issues, right? And making sure he's got good PMSs, good pulses and all this stuff. Make sure he's got good PMS and all his extremities, right?
Apply splints. Stop minor bleeding because you've already taken care of the major bleeding.
Yeah.
All right.
Thank you, sir.
Okay.
I mean, you can lay there if you want to,
palpate.
or
Yeah,
you
you
can
can
go
lay
back.
there. So sorry.
Oh, yeah, I forgot. He took some glasses.
All right. So look,
Everybody
listen,
give a
feel.
round of applause to our wonderful, smart man.
I'm sorry for hurting your liver. I'm so sorry. All right. So auscultation means listening, right? Sorry, I'm going to try and power through these so we can get this last one done. Decap BTLS, we know deformity, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. Our baseline vitals are used as an initial thing. We've said this multiple times, so make sure you're getting that initial set of baseline vitals. If there's anything stopping you from that initial baseline vitals, try to get them as soon as you can, but try to obtain them within 10 minutes, 5 to 10 minutes of your first initial patient contact. Whenever we're talking about trauma, I don't know why it put it in this section and not your initial section, but whenever we're talking about putting on a C-collar, you want to measure it, make sure you're putting the appropriate size on your patient. If you put one that's way too big, you're going to hyperextend their neck. If you put one that's too small, it's not going to do the job that it's there to do. So measure it. I like to use fingers. That's how I was taught. Same thing as your book. So you measure from the bottom of their neck where it starts here up, and then you just hold it onto the C-collar and see kind of where your fingers sit. It might be 4 fingers, it might be 3, and then you're going to place it.
Most people have swapped over to soft collars, so you'll still see like those really hard plastic, bulky looking things. But most people, especially in the emergency setting, have swapped over to like they're almost like foam, style collars, just because they're more comfortable. They still do the same thing, but they're better for the patient in the long term as far as like getting them where they need to go.
Mm-hmm. So whenever it comes to serious injury or multi-system trauma, if you are so like overwhelmed by the airway, breathing, circulation part of your patient care, and that's all you have time to do and all the hands you have to focus on, it's okay to skip out on that secondary assessment. Usually that's done en route to the hospital on critical calls anyway. And if you walk in and you tell the doctor like, hey, I didn't really get a good chance to look at the rest of him because I've been trying to ventilate him and suction him and all that stuff, nobody's gonna ding you for that at all.
We've done it, right? Like we've called, 10 or 12 gunshot holes on a guy that had 15. Like it's fine. The doctor didn't yell at us, didn't get mad at us. We were in the back, like busy doing other things. Like find your priorities and stick with them.
And your ABCs are your priorities. Okay, CMS we talked about sensation, motor, pulse. Note that pulse. Is it strong? Is it thready? Is it absent? Right? Here's that battle sign that we're talking about with the bruising behind the ears. This can be a seatbelt sign. So if they have major bleeding into their abdomen, that seatbelt sits right there. It can cause bruising like that. We're going to do a good chest assessment, head assessment. This guy just looks thrilled to be part of this. That back, easiest whenever you're getting ready to move them either onto a backboard, a stretcher, scoop stretcher, whatever you're moving them onto. Kids, like I said, don't poke on their little soft spots. They don't like it. Nobody really likes it. Remember, kids are obligate nose breathers. So if they have mucus or blood or anything major in their nose, that's going to affect their breathing. And then they're proportionally larger heads. Kids fall with their heads first, so they are more susceptible to spinal cord injuries.
Ironically enough, we have had a pediatric trauma doctor tell us that unless a pediatric falls greater than about 2 stories, he's not really concerned about it.
Which is crazy to me.
Yeah.
I was freaking out.
We took a kid to the trauma center in Atlanta that fell out of a 2nd-story window. Was perfectly fine. Nothing wrong with him. And the trauma doc was like, yeah, generally, unless they're falling 30 or 40 feet, like we're not overly concerned. Now, granted, in your book, if they're falling greater than 2 times their height or over 10 feet, be concerned. But that's just fun fact. So.
All right. So some things just to keep in mind, some tips. Explain to the patient what you're going to do. It's awkward if you walk in and start ripping clothes off, right? Expose the area before examining it. That's going to help you. If it's a big major trauma, get them trauma naked. Okay. Be considerate of spinal protocols. If you're maintaining C-spine, don't go jostling around, moving their head around, or like moving them on the bed like crazy. And then you can stop or alter that secondary assessment to provide care. So like Chaz was saying, broken leg, bone sticking out, we're going to stop our assessment and fix the problem. Our detailed physical exam, like we said, it's usually done en route to the hospital on really critical people. Yeah. Make sure you're continually assessing your patients, because patients like to change. So, your guy that was walking around on scene, excuse me, whenever you got to the MVC, like the car accident, and now his blood pressure is crap over crap. Like he can change, right? So continuously assess. Every time you perform an intervention, you need to reassess your patient. That includes vitals. Okay, so after you give a medication, you need to assess their vitals. Okay.
If you manipulate a broken extremity, you need to reassess pulses. If you put a sling or some
Matt,
sort
good
of
answer.
bandage on that
Good job, Matt.
extremity, you need to reassess pulses and CMS in that extremity, right? Because if I have somebody that's bleeding right here in the arm and I put a bandage on too tight and now they don't have a pulse in that arm, that's a problem. You probably need to loosen your bandage up a little bit. That way they have circulation to that arm. So one big thing that I like to touch on that's not going to be on a test or anything, but since we live in this state, it typically snows, it gets really cold. If you're standing outside of your ambulance or you're extremely close to your ambulance, please don't get these people butt naked in the rain and the cold. Don't just put them in the back of the truck. Get them warm. That's where they need to be, right? I've had paramedics that tried to do that, get people butt naked in 40-degree raining weather. Don't do that. All right. Be mindful of them.
Okay, y'all are like 8 slides away from being done, I promise. This is really, really fast. So this is about the reassessment. We just talked about that. We want to be continually reassessing our patients. Reassessment, we don't ever skip it, especially when we've done interventions or they're a critical patient. We definitely need to be reassessing to watch for those trends, right? Yeah, okay. Key components of reassessment are repeating your primary assessment. Their airways can close. Maybe they spring a leak somewhere and now they have, hemorrhaging, or their heart stops beating. We have to reassess those things. We want to repeat the vital signs several times throughout the call. We want to repeat the pertinent parts of the secondary assessment. So, if we find something that's pertinent, we want to reassess that and see if our interventions have worked. So that's number 4, check our interventions. So repeating the primary assessment, we're rechecking for life-threatening problems. Is the airway still open? Is our patient still breathing adequately? Reassess their mental status, maintain an open airway, monitor their breathing rate and quality, monitor the pulse rate and quality, and their skin color and condition. We want to repeat their vital signs. Continual reassessment of vital signs can reveal the trends. We've talked about that. We want to reassess critical patients every 5 minutes, unstable critical patients every 5 minutes. We want to reassess stable patients every 15 minutes. I don't have it on here, but she just mentioned 10 minutes for trauma patients, unless they're unstable. Okay, repeating pertinent parts of the history and physical exam. The chief complaint can change over time, especially in severity. So maybe they started at a 5 on the pain scale and now they're at a 10. So maybe your interventions aren't working. New physical changes might become present. So you might not have had abdominal distension before, but now you do. Or maybe now you're noticing paradoxical movement, things like that. And then we, again, want to check our intervention. So if we give a medication, did it work? Is it helping the patient? If we give an albuterol treatment, is that helping open their airways? Things like that. Ensure adequacy of your O2 administration. So if you're giving oxygen, is their O2 sat increasing? Are they breathing easier? Things like that. Make sure your bleeding management's effective. Ensure the adequacy of any other interventions you've done. So like Rebecca just said, patient condition can change quickly, so we need to continually be reassessing those patients so we can catch changes and appropriately treat them as our situation progresses. Any questions? Are y'all done? Done for the day? That's a lot, huh? That was it. And we were still on time. It's 7:31. You're right, 1 minute late. I'm sorry.